Hi everyone, it's Erick Iams. I just finished editing the level 2 Q&A session with Jeremiah Dees and my dad John Iams. The video went well. I think we went a little over time wise, so I didn't get to share everything I wanted to. Um, the links that we share in the video, I'm going to leave below in the description area. I also wanted to be sure to discuss the level 3 virtual option that's coming up. So as you can see, there are several different registration options. The question that came up during the Zoom call yesterday was, what are the exam recordings and technique demo recordings, or the lab practice recordings? So the difference between the two options really is whether or not you get the recorded versions. So for the basic and standard options, those are just to have the access to the live stream Zoom call. So if you can't make it for the entirety of the 3 days, we suggest going with the premium or the premium plan. And those are just, you pay one time versus a monthly payment option. And for those of you that are interested in seeing what the recorded version looks like, you'll get access to our membership platform. This is brand new. It's awesome because it tracks your progress. You can log in and log out, and it'll save where you left off. But as you can see, all the videos from the weekend will be shared here. So it's organized by techniques. There's Q&A, and also you'll get the level 3 bonus items. Now, I don't want to spend too much time trying to convince you of the level 3 virtual option, but I did just want to say that this is a rare chance to get level 3 and be eligible for level 4 for a highly discounted price, and that this virtual option may not be available in the future. If you have any questions about the level 3 course, please send me an email at support@theprrt.com. If you have questions or comments about the video, please leave it in the comments below. Now, without further ado, let's jump right into the level 2 Q&A session.
Welcome everyone. Good evening, good afternoon. Thanks for joining us. Looks like see Daniel, John, Jordan, Gerald. Let's see. I asked everyone just to keep their microphones on mute just until we get into kind of like the open Q&A session portion. So that'll help with our discussion just to begin. If you want to have your camera on, that's great. If not, you want to just listen in, that's perfect too. Some of you recognize, obviously, here, but some of you may not recognize Jeremiah. I see there were some students that were at the virtual course, but Dad, why don't you start with introducing Jeremiah to those who haven't experienced him before?
Yeah, Jeremiah is one of the top people that have come through our training. He not only has absorbed and is able to practice at an extremely high level, he's very creative, and he continually challenges me to come up with new approaches, better and faster ways to make PRRT even more effective. So it's good to have him on board, and he'll be able to share any thoughts that you folks have questions about when we get started here.
I think he might also be the only PRRT practitioner with a world or a national championship and a course record. Right, Jeremiah?
There's got to be some other major athletes in here.
Well, I was an All-American.
Major athlete anymore.
Yeah. We have a selection of questions that others have sent in. So I figured we could start there and then kind of open it up to the group and see if there are more questions along the way, or well, after we get through those. How does that sound to you two?
Sounds good to me. Great. Yeah.
Okay. I see Daniel is actually joining us. I think I want to say Daniel's in Europe. So thanks for staying up with us late, but he was the first question that we had. And it kind of teases into level 5 stuff. but I wanted to hear your guys' input and feedback on this. He said he was a virtual student who just joined us for the last combined course. And he said when he was watching the recordings, he, during the demonstration of some of the techniques from Jeremiah, he visualized Jeremiah or someone else treating him with the techniques, and he got a massive shivering in a positive way in his body. He can reproduce it anytime he wants when he visualizes and quote unquote feels how the technique is applied, even though he's never felt it yet. Do you have any sense of what he's experiencing?
That's a question for Jeremiah, isn't it?
Well, I'm wondering how that relates to.
I mean, sorry, go ahead.
Yeah, I was just going to say, how do you think that relates to kind of like the global parasympathetic reboot, and how, Dad, you incorporate the smile like you see in a long lost friend, and kind of the emotional aspects of what we're working with as far as PRRT goes.
Yeah, that's my sense, is that there's, that we're triggering some emotions that I think are very positive and can be very supportive of what we're doing with our manual approaches as well. Jeremiah, you got any added thoughts on that?
Sure, that's what I think about. What comes to mind right away is what John often says, which is the phrase is, just lost it. The phrase is the endogenous opiate release.
Mm-hmm.
That can be triggered a number of ways. We do the startless maneuver, which will trigger, like I just felt some of that now, just doing that and showing you. But that can be triggered by what you're describing, Daniel. Absolutely. I felt that in my life before I found John and PRRT. Being someone that's had traumatic experiences previously in my life, there are things about how we feel, like John's saying, that trigger our emotional system that can cause that feeling. And I would also say it's about things that matter to us, that matter innately to us. So in the last class, I kind of got coughed up a little bit when we taught Startless, because I was talking about a little bit about what I went through when I was younger, and just explaining it. And somebody said, well, they could talk about it now without, responding to it. And that wasn't what I was responding to. What I was responding to is much like what you're describing here, which is, for me, something that's like really core to who I am and what matters to me in life, like just personally, is that is what I did with the negative experience and trauma that my body experienced, rather than right. The first step is to learn that you're a victim of something, but then you learn how not to be a victim, and how do you, instead of take that into vices and into things that by definition don't serve us, can you actually turn that positive? And with athletics, that was my avenue. And that I learned things in athletics. I was just telling one of my new 14-year-old rowing students this today, that I said, this is the start. And I said, he was telling me that he's going to go to San Diego this weekend for this. He's like, I can get out of school on Thursday and Friday so I can go to this race in San Diego. And I said, here's the start. I said, by the way, I'll let you in on a little secret. Most of the most specialized things I do that people say no one else practices like you do, or they don't have the touch you have, or the intuition that the people I've been treated by, like, and they're good people, but there's something you do that's different. And I told them, I said, that stuff came from what I learned as an athlete in the process. And so what kind of hit me in the last class when I was teaching Startless was kind of that hit me in the head, kind of that. I realized it before, but it kind of hit me at the moment that here I am able to teach other people with whatever backgrounds they have, whatever valuable experience and backgrounds they have, and to add this tool to their belt. And yeah, there's a lot of things I've done and been successful with, but what it really comes down to is the thing that really started this whole cascade for me was when I was 14 and went through, the 11 to 14 and went through the stuff I went through, and being able to turn that into something really positive, and to be able to help and treat other people that have had those types of experiences, but also regular old people that haven't had the misfortune of having those types of experiences. And so this is a long-winded answer and a little bit of a tangent, but it's related to that. Can things that matter to you at the core trigger that feeling in your body? Absolutely. Absolutely. Anything. I think the key is that we keep our minds as practitioners open to, there may be multiple reasons or different reasons why people feel the things and respond the way they do to the techniques we do, because we are literally communicating with their nervous system. And in especially in PRRT, what we're most focused on, I mean, it's not only focused on, but we're most focused on the autonomic nervous system. And that is one of the most primal systems. It is our threat detector, our protect the body, am I safe in the world, am I okay system. And it's our adaptation system for whatever the environment we're in is. And so we're literally, with the PRRT techniques, communicating with that directly. And so you're going to get those kind of feelings for lots of different reasons.
Very, very well said.
Yeah, I think that I mean, it's just kind of a good point to remember that there is a huge emotional component that, we're also working with, right?
Right.
Mm-hmm. Yeah, Dr. Sharma couldn't join us, but he sent over several questions. So I'll start with the first one. He asked, what is the importance of assessing the spermatic cord in the 2-minute exam? And do you have any tips to assess it correctly?
Jeremiah, you want to take that one?
Sure. John and I were actually talking about this a little bit earlier, and just to make sure that we're clear on it, or that I'm clear on his intentions too. What came to mind right away was, in the slide when we presented that, is that the spermatic cord is very much part of the internal oblique, right? It actually, John was saying that to him, it looks like, he can't find it in literature anywhere, but it looks like that it's actually formed from the fibers of the internal oblique.
Well said.
Well, I learned from the best. And when I look at that, I go, yeah, I see that. That makes sense to me. I mean, if you just look at the other side of the body, we do know that the iliolumbar ligament, right, it's formed from the QL fibers, right, in the teenage years of life. Mm-hmm. So, I mean, is it a stretch to think that, the spermatic cord has this kind of relationship, given the way that development happens in the body? I mean, not at all. If it is or not, doesn't really matter. It's definitely part of the structure. Like it's directly part of it, right? The spermatic cord is embedded in the tendons and connective, tissue around the internal oblique. And so the key there is that we want to be aware it's there, so that if we're palpating the internal oblique, we don't inadvertently kind of manhandle the spermatic cord. I think John's note page says tread lightly or palpate very gently or something like that. So it's not that John made it, he's repeatedly in the classes I took, and we talked again and said, I don't think anybody should actually be palpating the spermatic cord itself. It shouldn't be our target. I mean, unless you're a practitioner that has a reason to do that, and that's part of what your scope and what you do. It's just more about being aware that it's there, and it may influence the internal oblique. I think about it that way. Like if I have a male patient and they've got any kind of pain also that's, in their genital region, when I'm palpating their abdomen, I'm kind of thinking of, I'm like, oh yeah, that's something I should be aware of. Maybe, is it abdominals triggering this, or is it pelvic floor triggering this, or some organs triggering this, or is it that triggering the abdominals, that kind of thing. And just trying to figure out just be aware of the relationship.
I figured I'd pull up, kind of skip forward. So
Okay.
everyone should be able to see the pulled groin, because he had a question. If possible, could you elaborate on the pulled groin hip flexor release technique? So I pulled it up. Can you see it on your end?
I can see it. John, you want to talk
Okay.
about this one?
Yeah, you're seeing my hands going in and preparing to do a release, a fascial release of the internal oblique fibers as far down as they tend to go. And, you know, it's something that you can do with a very short amplitude and a fast speed, but not enough to be able to have the person react as if it either startles them or hurts them when you do it. So it's more just a matter of being subtle, but being able to palpate the opposite side, because usually it's not bilateral in terms of the findings. So you can use the other side as the control and try to achieve that same feeling, because there shouldn't be any NSR or adverse effect by just doing a deep palpation of that area.
That's a good point to note that for level 3, we get into grade 5 fascial, the most common areas to incorporate and use the grade 5 fascial releases. So that's kind of a peek into, fascial releases as they work to integrate with PRRT. So just to tease it forward for everybody that's on the list for level 3. I think we can go back. Go ahead.
Can I add one thing?
Of course.
Can I add something?
Mm-hmm.
Fascial release is probably one of the most important approaches that isn't often provided for people. And when I see people, even today in my private practice, I usually only have to see them one session. And, when you can make a change in people in a single session with doing fascial release the way we're teaching you, this one patient I just saw recently, he's already referring other people to me. You're going to start to get more people coming to see you because they're going to hear the rave reviews about the work that you do and the fact that you can make a change that quickly. So just to be thinking about that.
The next question Dr. Sharma had was, how does treating the right side, for example, stylomandibular ligament, improve the opposite side? Is there a reciprocal inhibition relationship that also exists between ligaments? We got to talk about this a little bit earlier, but I wanted to.
This is another thing we
share
talked
with the
about.
group. Mm-hmm.
Yeah, that there's nothing in the literature that will say that there's, we don't have stretch receptors in our ligaments, right? But what John noticed, and I've noticed the same, and many other people who have learned from PRRT have noticed, that you can, if you've got stylomandibular issues here, you can bounce on over here, and you get a response, or you get pain relief here. Now, is that reciprocal inhibition? Ligament to ligament? Probably no, because there's no actual reflex wiring. But there's all sorts of other things in the body that are wired across from one side to the other. So just think about if I'm, think about it like if I'm providing an input here with my left arm, right? That's for the right side of my brain, right? That's handling that. Now, the control and sensory is there, but then if one of the things that does pain modulation is the reticular formation, right? Well, that's ipsilateral, right? So if I do this, I'm affecting this side of my head. That's going to have a pain modulation effect straight down this side of my body, the other side. Could that explain this? Absolutely. Is that part of this? Probably. Right? We have central pattern generators in our nervous system. We have all sorts of other types of wiring When I go into the stylomandibular ligament, am I only touching that ligament? There's no way, right? I'm going through skin, which has tons of receptors in it, fascia. There's other muscles in this area that you can't avoid from hitting. So are you going to have reciprocal effect on those muscles surrounding the area? Sure. So so is it literal reciprocal inhibition, stylomandibular ligament left to stylomandibular ligament right? No, I mean, there's nothing in the literature we'll find that says that, but John noticed in his practice that he got the same kind of effect. And I've noticed the same thing others have, and I just gave you a few right off the top of my head from neurologic knowledge of ways that could happen, and I know of others. So what I would add to this, and it's going to answer some of the other questions here. You're going to have the most success as a practitioner. If there was any one thing that's going to give you the most success as a practitioner with the tools you have, whatever they are, it's going to be that you follow what your patient's body and your patient guide you to. So let me say that another way. It's the same message, but let me say it another way. It's going in with the mindset that you don't know everything, and that all the stuff you do know to be true and factual may not be the whole picture, and likely isn't ever the whole picture. Probably never, no matter how much you know. Because all of us that have learned about the body learn how complex this thing is, and we become aware of how much we don't know, right? And the people that read the most literature, the ones who really read and understand, they'll tell you, man, I know all this stuff, and yet I just become more aware of how much I don't know, right? Or how much I can't be 100% certain about. What I've observed in my career, doing this for the last 23 years, is that the people, the clinicians, no matter what you want to call them, no matter what their background is, that go in and think, well, I taught it works like this, and it works like this, and it works like this, and if it doesn't fit that, it's not, something's wrong with you, or something's wrong with, or you need something else. You need someone else who has this or this. What I find is those people often miss what the integrated picture really looks like, which is consistent with how we all know the body works. Everything parts connected, everything else, all the functions are connected to everything else. It's an integrated system of systems, all living, it's what makes us living, right? It's what all living organisms are. That's what makes us different than machines. So it's really important as practitioners that we go in with an open mind, knowing the things that we know, because we are going to use those, but not being so entrenched that if we see something that doesn't match what we know, it tells us, well, it's not that. Because it might be that in a little nuanced way that you're not aware of yet, or that nobody's aware of yet, or that only some people in the world are aware of yet. And if your mindset is such that, well, what I'm seeing is real, is what I'm seeing, yes, it is, that's real, how do I explain that? Then what it'll do is it'll lead you to seek the answers that are right for the person in front of you. And you're going to do the best you can with the tools you have to help them. But what you're also going to do is what John's done his whole life, and what I've done my whole life, and what Gil Jackson, the chiropractor who helped me find PRRT, and John and Erick, that has done his whole life and still does to this day, is you'll look for the answers, and it's going to guide you outside the current field you're in, and you're going to start learning from people from lots of different fields and seeing how we all fit together.
I couldn't have said it any better.
That kind of reminds me, Jeremiah, and I don't think that everybody here has experienced Dad's prior introductions to the seminars, but he talks about the EBDBs. And I figured maybe you could share what that means for all those that are viewing.
The heebie-jeebies?
EBDB, ego-based decision bias.
I don't remember that.
No?
I don't remember that specific term.
I'll take it from there.
John's got it. It's his term. He's got it.
Ego-based decision bias is
Ego-based decision. Yeah, I remember that.
my interpretation that we have a tendency to have our ego being so important in terms of the patient's response to what we do that it drives us to make decisions that aren't as accurate as they would be if our ego wasn't playing such a big role. Meaning we should be focusing on what we find based on their history and then making an assessment of trying certain approaches and seeing what changes there are and finding what works and what doesn't, and then giving the person a program to work with at home if there's things that we feel that they need to do, whether it's nutritional or whether it's to do certain maneuvers that we teach them to do. All of these things are very important and part of what I think has to be part of our focus and not just our hands-on approach.
Yeah, thank you. I want to put a pin in that for time being because we had one more technique question, but I think it's going to relate to future questions that we'll get to. I'll pull up the technique page again. We're looking at the longest coli release, and Dr. Sharma was asking what effect does counting to 20 have during the longest coli release?
There's a short answer to this question.
Mm-hmm.
Every time you make speech, the longest coli activates. Yes. So you're just trying to time your tap with the activation of the muscle. So it also having them repeat. So the cue is, I want you to count to 20 slowly, out loud, one word at a time. Because they go 1, 2, 3, 4. You could have them count with the alphabet. You could have them talk if you give them just keep talking, which I actually do. If we're having a conversation and they're talking, I'll have their head and I'll just, and then they'll stop talking. No, you keep talking, I hear you. And then they start talking and I ping them and they're like, stop. And no, I hear you. This is actually part of the treatment, by the way. And they kind of, really? And kind of laugh and, and then I've told you, I said in class, and then I got to get them laughing and like, now I got parasympathetic upregulation, it's super strong, I'm stacking the effect. But every time you make speech, you activate the longest coli, and when you activate the muscle and ping it, you get a better inhibition response.
Beautiful, thank you. Brent sent in a couple questions, and we kind of touched on it already, but he's asking, what are the most important level 1 and 2 techniques, most important of the 4 dozen reasons, and what's new from when he attended almost 20 years ago?
How long ago?
But it's almost 20 years ago.
Oh, wow.
19 years ago.
Yeah, we're all a lot older. I know that. Well, so Jeremiah, would you say from level 1, it's got to be the primals, right? If somebody said,
yeah,
you can only select a handful of techniques to use with everyone from level 1, the primals are
the primals.
The first 6 techniques in level 1. But I was having a conversation with our instructor, Tara O'Kelly, in Ireland recently, and I shared it with Dad, and I think he could touch on it as well. But diaphragm should, she was saying that her students, and she kind of agreed that diaphragm should almost be included in the primals, and it's kind of one of the things that's covered at every level. So yep. What are your takes on the importance of diaphragm?
It's critical. I would agree. Like when I've taught, I always show people the primals, but then I add things in that are taught in other levels that are just part of the flow. But the way I think about it is anything I can do that has a global sympathetic downregulation effect is what I want to start with. I don't rely on that being my whole treatment, but I always start there because it makes everything I do as a manual therapist work better by calming the entire autonomic nervous system. So the primals and the diaphragm release and the intercostal release, and I would add scalenes to that, stuff around the ribs and breathing. If you can get and then stuff in the neck and jaw, right? I'll add some of those things in. Anything that can downregulate those areas, the system itself, and those specific areas that tend to always be upregulated when you have sympathetic activity. I'd say those are the most important things. The next question being, the most important of the 4 dozen reasons why. I think that was, you guys said that was why PRRT doesn't work. The 4 dozen reasons why PRRT doesn't work. My answer to that would be 2 words. It depends. It always depends on the client in front of the patient, client in front of you. What they bring, their situation, their environment, their history. The right answer always depends. So the most important is you getting it right so that your treatment is on point. And the only way you're on point is if your assessment is good, meaning your eyes and your ears. So listening, watching, asking questions, coming back to John's thing about the ego, drop your ego and talk to them and try to understand them. My employee Clayton, years ago, we were working in a medical practice for 3 years with internists and OBGYNs and therapists and everybody, like a whole clinic of integrated physicians and clinicians. And I had Clayton shadowing me as I did assessments. And I asked him the first time, any questions? Like, what did you learn? And he looked at me like puzzled. Because you tell people what you don't know. I said, of course. How do you think I solve these problems? Like, I don't solve them. We solve them. Like the patient and I solve them. They have way more information than I have. I have more knowledge about the body than most of them have. Almost, probably all, but the vast majority of them. But they have more information. They lived in their body and they don't know what to tell us. And so you have to have your eyes and ears open to know what the right reasons it would or would not work is. And I don't think of it as will PRRT work or not. I think about it as PRRT the right tool for what they need. And what I've found in my practice is that of all the different tools I have, if we want to classify them, where I learned them from or what field they fit in, like I don't like any of that stuff because I've already told you, I see the body as an integrated thing and I see the world as I'm a biologist. I mean, I get how everything's connected. The most important thing is not the reasons, it's understanding where the stuff you learned in PRRT fits into how you're going to help this person get to where they need to go. And that involves, it depends. You have to be able to listen and assess. That's the answer to that question. It's not an easy answer. It means put your clinician hat on and be committed to it and don't give up. There's a joke with some of my patients, and it's not arrogant. It sounds arrogant to those who aren't in on me. But the joke is Jeremiah always wins. And it's a comment about persistence. Back to, if you don't have the answers, are you going to go find them? Where does their situation lead you to search? Have you made the professional relationships with people in other fields who have knowledge and abilities that you don't have and that you're not going to go develop? Do you have those relationships where you can work as a team with those people on treating patients and clients? And so it's really, it goes back to, what we often call the hub and spoke model, with the patient inside and a team of people around them connected through the spokes to the patient. And we work as a team, whoever, it's not always all of us at once, but it's like, which ones of us are most pertinent right now for the person's situation? And if that's our mindset and we're using PRRT as a tool on our belt, it's going to facilitate that. Plus all the other skills we have and the relationships or the skills of other professionals we have, we're going to find an answer that's helpful for them. if we think we have all the answers or we're supposed to have all the answers, you have a lot of people you can't help, where they walk in your office feeling better and just goes right back, and you just become the next person that they say, oh, I feel better when I go to somebody, but then I go right back and I'm not making progress, right? And there's different versions of that story, but it's all the same story. My problem's not getting solved.
That kind of leads us into the next question from Michael. He said he's treated clients using PRRT, and when palpating, he notices, I think he means the 3Gs, return, the gasp, groan, grimace, the nociceptive startle response. He asked, can they be permanently cleared? And that kind of ties us back into, what about the 4 dozen reasons? You know, I mean, what are your thoughts on that, Jeremiah?
I think it's what I just said. What I would say is when the sign, the G's return, to me, what I take is that, because I can feel people's bodies change in my hands, and I can see their expressions change, and changes in their voice and how they talk to me, their tone, I see it all. But when things go right back, that tells me I haven't found the root. I haven't found the root of the problem. That I've got the puzzle partway solved, but I haven't found the through line yet. And so I don't take it personally. This is again, we're not having, you want to have a healthy ego, but not a, you don't want to give up, and you want to solve it because it matters to you and it matters to them. But it doesn't mean that you've done anything wrong. It just means you're not there yet. It's kind of like I'm a mountaineer. It's kind of like anybody who's climbed a mountain or done a hike up hills, and you think, oh, there's the summit, there it is. And then you get there and you're like, oh, now I can see the real summit, right? It's called a false summit. If I was going to make an analogy, I treat their body changes and then it comes back. That's kind of like reaching a false summit. You've done good, but you have not solved the puzzle. You haven't arrived at the summit yet. If you're making a puzzle, oh, wow, I can see what this puzzle is going to look like, but it's not, all the pieces aren't there yet. And you don't actually have it all figured out yet. There's some pieces you still have to find and go, I know what's going to go there, but which ones are they in, right? And that's what's going on. So don't take it personally. Just keep your nose to the wheel and keep working at it. I think the natural thing I would add to that, I think John would probably add to that, is, because I've heard John say this in most of the classes, I call it, don't beat up the patient if you're doing massage therapy, right? Don't overtreat. But John says, oftentimes you're not going to get a perfect result. You're looking for a change in their body to respond. And sometimes their body and the nervous system needs some time to process. So John will often recommend that he sees somebody 3 times over 1 month or 5 weeks or something like that. And he says, give your body a chance to absorb this and respond to it, and then I'll see you in 2 weeks, right? Because I want to know how your body responds. And there is no wrong answer. There's just the response their body has. I've had some people who they're not common, but it happens, where they actually have a negative response, and it's because I've changed the status quo in their nervous system, and they're so worked up and wound up that their body compensated into a place that they could get by on. And like, I hurt, but I can manage it, and I can sleep kinda, and I can get around. And then I do all these things that feel like, oh my God, your body's loosening up and changing, and it's great. And they call me and like, I have the worst headache the next day. I'm like, is it like your others? No, it's different. But anything else changed? Well, that other pain is not so bad, but now I've got this horrible, and I can't even function. I'm like nauseous, and I'm like, whoa. It's hard when that happens for me, because and I think it'd be hard for anybody, because we want them to have the positive effect. But what we've done is confirm that we've changed something in the nervous system. And what that tells me is, oh, I need to help them come in right away and feel good about it, and not feel like I've hurt them, right? But their nervous system needs help. And that kind of person, I try to get them back in as soon as I can, so we can take the next step and get them to a place of balance. Like I don't know what that's going to be until I get them on my table and I can like find out, how is their body responding? What has it done? Clearly I robbed Peter to pay Paul. So how do I not maybe put them back, but how do I get them to a place where their body feels they're okay? So think of it as everything's information, and what is it? Instead of wrong or right, it's information, and it tells you, what does it tell you about their body and what it needs, right? Because their nervous system is going to tell you what it needs. It's our willingness to follow that rather than dictate it. Well, this is supposed to work. That's not the right answer ever. Like you can say it, but it can't. But then you got to do the right thing going forward. It can't be like, well, it's supposed to work. What's wrong with you? Because you're implying what's wrong with you, right? Which is never the right answer ever. I rarely say always and never, but that is never the right answer ever.
Ruben asked if you have experience in relation to subscapular problems. Jeremiah?
And then he asked, do you have any technique for tongue and eye muscles?
Yes.
Yeah, I'm subscap all the time. I mean, one of the most underlooked, areas, just because it's not obvious. You have to get between the scapula and the rib cage to get it. People don't like you poking around in their axilla, in their armpit. It hurts for a lot of people, especially people who end up in our offices. For that one, I can't get into all of it in this call. A lot of ways I go about it. I mean, the direct way I made up. If I test if their infraspinatus and teres minor hurt, and I basically have some way for them to do external rotation. I'm not a big fan of this one because people often have elbow issues or they get too much in their hand. So I really like the straight arm and roll this. I'll find a way though to get them to load their infraspinatus, and I'll either tap it, or sometimes what I like to do, one that I really like is I have them put their hand on their belly. This angle is down. They're pretend I'm laying down on my table, and I'm the patient. And I just say, put your hand on your belly. And I'm like, take your hand off your belly. Or I'll say, try to backhand me, right? And I'll be right here. And the moment they start, I just push them back down. So sometimes I do that. Sometimes I'll have them just out here, and I'll just put my hand on them, and I'll say, here, just try to backhand me. And they're like that. And I'm like, okay, don't fight me, just backhand me nicely, And they start squeezing, and then I'll just reach back and with my fingertips like that, I'll just tap on their infraspinatus and teres minor tendons, and I can usually get a release. And then I go in as a manual therapist, and I actually feel, the more I can get in there, and I don't think of like I'm beating up the tissues after that. I think I'm trying to get their body to volunteer me in. They're going to let me in. I'm kind of holding their arm, which pulls their scapula and gives me a space to get in there, right? It pulls the scapula off the rib cage, right? And I've got their arm, so their brain still senses, I'm okay, you got. I always tell them, I got you, let me have you, I got you. And that's really important. Their brain has to know you have them, otherwise it tries to hold. And then I get in there, and I'm just using my fingers to try to make sure everything's pliable and feel what's going on. You could do trigger point release, you could do whatever massage techniques you have. But for me, my mind is, yeah, all that's fair game. But in the end, what I want is their nervous system to let go. I want their nervous system to let go of that subscap. What is it holding? Why is it holding that? So maybe it just needs to be in there now that I did the neurologic release, and it let me in enough to go, oh, actually, that's okay. I don't like it, but you're not being aggressive. You're just in there. Oh, actually, I'm okay. I'll let you have more. You're okay. I'll let you have more. My goal is just to help their body let it go. I'm not trying to beat it up. That usually works.
One thing I'd like to add, you're giving such great ideas. One thing that might help would be to check the opposite subscap area, particularly if they have no symptoms on the other side. Use that as a control for them to see what you should be trying to achieve on the involved side when you're palpating the subscap area.
Really good point.
Great. So thank you,
Next
Jeremiah.
question, Eric.
Yeah. He also asked about techniques for tongue and eye muscles. I wanted everybody to know we go into a tongue release in level 3. When I spoke with you earlier about this, you also mentioned that you had purchased Dr. Lopez's tongue release course. It's called The Tip of the Iceberg, and he created a course specifically for PRRT practitioners. So I'll drop the link to that in the chat box if anybody's interested in checking that out. I think that, did you have anything that you wanted to discuss on eye muscles? We have orbicularis oculi and some of the techniques that deal with muscles around the eye, but I don't know that we go into specific eye muscle techniques.
No.
Yeah.
No, there's for me, that question leads into like other neurologic type drills and training. Like you're going to get into actual vision drills, so I would look for information on visual training. There's I'm taking a continuing ed course right now. It gets into it, so you could buy a book and read about it. Like there's I mean the basics of it are what it comes down to is you've got 3 really major systems. You have the visual system, the vestibular system, and the proprioceptive system. And the way to think about it, one of the ways to think about it is they're kind of like a hierarchy in the body, right? And we use all 3, and then when all 3 are communicating and making, the brain's getting information from all of them and makes sense of things, it's like, okay, I'm okay. But when the brain gets different, conflicting information from the visual and the vestibular system, you're going to start having symptoms, right? The eye muscles are part of that system. So do we treat the eye muscles directly with PRRT? No. Do we use them in a bunch of PRRT techniques? Yes. Like we talk in the higher levels about using the eyes, using like conjugate gaze, and using the eyes to help with some things, like for the rectus capitis posterior minor, right? John has us look downward. Well, what does that do? It makes the rectus capitis anterior minor activate without you actually looking downward, right? It'll actually activate it. And is that going to cause reciprocal inhibition on RCPM? Yes, it is. Is that going to involve the eye muscles? Absolutely. So I can't think of off the top of my head. I've never run into someone where I'm like, how do I treat the eye muscles themselves? But eye functions, absolutely, right? Our eyes are supposed to converge as things come closer to us. They're supposed to diverge as things go away from us so that we can stay focused. We're supposed to be able to fixate our eyes on something so it doesn't look like a blurry tube, right? We have peripheral vision, like, where's my camera? Like I should see things, out here, not here, right? Be aware of them up here. Like there's a whole set of things, visual things that I think if you started trying to think about, if you're actually thinking about treating the eye muscles, I think what you're actually getting into is treating the visual system as a whole. Is it tied to what we talk about in PRRT? It's autonomic? Yeah. Is it the autonomic system? No, it's just part of it. So yeah, we integrate with that stuff, but it's not in our classes. We're not currently teaching the vision system like neurologic drills for it.
Right. Well, I think that's a good place to bring in Gerald's question, which was that John seems to integrate alternative approaches. What alternative approaches most recently do you find most beneficial? Do you want to share which program that is that you're discussing, Jeremiah,
sure.
that you're referring to?
So we've recently met a lot of people who've done the Z Health program. They get into this stuff. The founders have split and done a spinoff that's not quite as involved. It's called Next Level Neuro. So it's a little more, still time intensive, but it's a little more to the point. Not going to go quite as deep. It's less expensive, less amount of time to get through it. I'm aware of the Carrick Institute. There are people that go through that, which is like majorly involved, like neurologic training. So there's obviously books on it too. I don't have any of these specific books. I try to learn this stuff from people that actually use it. Because when I went to college, like I learned about all these nerve assessments, and I've seen people use these from these other programs. I'm like, okay, cool. I know what that is. You know, I've seen that before. That was part of my education. But what are you doing with it, right? And that gets back to this question: what do you find the most beneficial? My business is called Integrative Fitness. I mean, there, Integrative Fitness. Technically, my approach is alternative because it's not set in any one field. I kind of some people tell people I'm a physical therapist. I'm not. I was headed there, but I never finished and went to school. Some people say, oh, he's like a chiropractor. I'm not. Some people say he's a personal trainer. I didn't want to, like, I took those tests just so I could get insurance. Like after college, I have a human biodynamics degree from Cal. Like, and I was studying when I was 14 and asking the kinds of questions that my research professors at Cal were asking. And so they started talking to me when I started asking questions in class as a sophomore. They're like, that's a good question. Let's talk after office hours. Because I was asking the kind of questions they're asking. I was like, I can't find an answer to this. And they're like, well, and I talked to them and find out, oh, there's a good reason I can't find an answer to this. Nobody knows the answer to this. And these guys are some of the top in the world in this field, and that's what they're looking into. For me, I'm a biomechanist. That's what I am. I'm a biomechanist. And I've always known that the basis for biomechanics is the nervous system. So that's why I always tell people when I start teaching in this class that I am so humbled to be around people who value and understand the central role of the nervous system. And that's really what it's. We're not treating muscles and tendons, and we're treating the nervous system. So for me, I integrate everything I learn into a central understanding of how things work. So that's all biomechanics is the life system support for mechanics, right? For how we work, how we exist in the world physically, which is also mentally and emotionally and spiritually and all those things, right? There's a physical basis for a lot of this, for all of it. So, you know, in my practice, I've modeled movement literacy. I've taken what I've learned from all these different people and I've modified it a little bit because I have a more global perspective than every single one of them. And I've taken pieces that are great, and so I have a model of like we're building up this pyramid of skill and tuning the systems that support that in somebody's body. And if they fail, they're falling down this funnel of compensation and dysfunction, which leads to injury and pain, and get into disease issues too. And so the question for me is just, you know, what approaches does the person need? So for me, it's PRRT is a key part. Does it solve everything in the people I work with? No, I can't think of a single person that I've treated where PRRT solved everything. It's all they needed, right? No, they need you. They need you and your special skills. If you're a chiropractor, they need you. If you're a PT, they need you. If you're a massage therapist, they need you. If you're a personal trainer, a physician, whatever you are, they need you. They need your specific skills that you own that nobody else does, but they also need you to have this global approach where you understand how your skills fit with others and you can see what the patient needs. And so specifics, it's hard. I mean, for me, the critical thing has been listening and coaching movement evaluation for me. Movement evaluation, hands-on physical assessment, having a neurologic understanding of the body and how that ties into development, learning, relearning, that kind of stuff, autonomic responses, So I can tell you, if John's background was PT to start, ended up in osteopathy and acupuncture and acupressure and even chiropractic work and even dentistry. Like I knew John for I think 5 years before we were in a class. I was teaching and I saw John adjust somebody's neck off, on a break. And I've seen John treat people for 5 years, and I knew he had studied chiropractic, and I'd never, ever seen him adjust somebody's neck. And I didn't know that he knew how to do that. I knew that he knew about chiropractic work. And I told him, and he said, well, I just don't have to use it very often, but sometimes the case presents itself, which is just the right thing in the chain of treatments I do. And sure enough, it was helpful. And I'd never seen him do it. And yet, bam, it was the right thing. So I think I've given I've long-winded answer. The background on that question is going to be you need to have to be effective. We all need to have a broad understanding of what's out there. And it's based on how the body works. It's not based on some technique that somebody's named after themselves, right? This is primal reflex release technique. My business is integrated fitness. It's not Jeremiah Dees, biomechanics. You all should listen to me. Like, it's not who I am. John didn't name this business after himself for a reason, right? Primal reflex release technique is about all of you, about clinicians, all of us, just recognizing the autonomic nervous system is a central player in people's pain and compensation and dysfunction. It touches everything. And historically, the medical system, the wellness system, and the fitness system in our country and in a lot of countries around the world have not adequately taken that into account for millions and millions of people, right? And so PRRT is an effort, has been John's lifelong effort, and something that we're working to continue to make sure, grows in a way that people can utilize and understand in all these systems that bring tons of value to treatment, to help people thrive and live the life that they're made to live with the purpose they're made to have, and not be in pain and dysfunction all the time.
That was very well said.
I'm sorry for being so long-winded, but all those points are, I think, important.
The last question I had on the list was from Brad, who was interested in hearing your thought process during a session with your clients. Do you have a specific place that you begin? Where do you end? What do you fill the middle with? I know I think, we've said it several times already, but it depends. Do you have anything thought-wise to share with Brad?
So the idea of to fill time is not something I think much of unless somebody's coming to me with the mindset of, I just want you to make me feel good. I'm coming for a massage, right? For example, that would be the most obvious. Then we are filling time, right? Because it takes time to do techniques or a sequence of stuff. I would say even in that case for massage therapists, my goal is to help massage therapists see that they can help them learn PRRT, make it part of their curriculum eventually. So they realize, oh, I can treat their nervous system in a few minutes, or I could integrate this stuff, these little techniques into my treatment and still give somebody their hour or hour and a half long massage that feels really good. But that doesn't necessarily heal the body, right? I think a lot of us can agree that massage feels good to most people. I know plenty of people it doesn't feel good at all to, right? They don't go get them. But for the most part, we think common knowledge is massage feels good. But massage therapy to me is something that's different. Massage therapy is different than massage, just the way I like to say it. Meaning that if you have a PRRT background, I don't even name the techniques. If you understand how the body works, if you know about neurology, if you understand how this integrated system works, You know, and then you would say that a Swedish massage is not the same as somebody who's integrating all sorts of different techniques to give you manual therapy, right? That includes massage, right? They're two very different things. One is a sequence of stuff. It's a routine that feels good and should feel good, unless the body is really worked up wrong. The other is listening to the body and targeting your treatment and having multiple sets of skills to select from to find what's going to work best for the person. So how do I use my time? Well, they come in with a chief complaint. I talk to them. I have a questionnaire beforehand when they start. I'm listening for and I'm interviewing and finding and pulling more information out of them. I'm learning. I'm trying to get the whole picture. And I'm assessing them. And then I'm thinking about what I'm seeing and observing and going, what does this person need? What's the, because I see all this different stuff. And I'm going, what does the ball of knots look like? Or what's the, they have a root problem and a through line, but what's the cascade of issues that it looks like to me? You know, because by the time they come to me, that's not one problem. There's a lot of problems, but there's only a certain set of problems that are the through line, that are the root chain. The rest is just the result, right? The compensatory chain and symptomatic chain as a result. And so that eats up all my time, figuring out what they need. And then ideally I get to that early. Sometimes it takes a whole session. Sometimes it's very quick. If it's very quick, how do I fill the rest of my time? I'm actually coaching them on what to do. I'm either providing manual therapy to directly treat what I want to treat the way I want to treat it, to get their body where I want it to be, or I'm teaching them movement or cognitive skills. And I'm not just teaching, I'm coaching them, so that I in my mind, there's a very big difference between coaching and teaching. Teaching is, I have information, I'm gonna give it to you. Coaching is, you need some information, you need some understanding. I'm gonna help you understand this at the level you need to understand it in a way that you're competent to do what you need to do. And so coaching is different than teaching. Teaching is being an instructor, okay? And in my practice, I don't wanna be an instructor. It's boring to me. I wanna be a coach. And I think coaches, in my mind, serve one of the highest roles in the profession, because coaches actually listen to understand, and they problem solve, and then they come up with solutions that are on point for the patient. And that's different than saying, you need to do this way. And I think it's critical that we do this. This has actually been one of my pet peeves since I was a teenager. I find it abhorrent that we take people that are injured and recovering and we go, here's a sheet of stuff, do this. Because anybody who knows anything about how the body works knows that they can't do that the way you want them to. It's impossible. Even if they understand it, they can't. Their nervous system is adapting away from that for a reason. And if they try to force it, it'll adapt harder. So you have to be a coach. If you're a physical therapist, you have to be a coach. If you're a chiropractor, you have to be a coach. If you're a massage therapist, you have to be a coach. You have to figure out, how do I shape their experience with the tools I have so that their body gets the response I want, or that they want, that they need. And so that's how I would answer that.
Thank you. That covered the list of questions. I know we're just over an hour. Do we have a few more minutes with you, Jeremiah?
We do. I got someone in 20 minutes.
Okay. We actually have.
If anyone here has a question for John or for me or for you, I'd love to hear it.
Yeah, Martin just replied that he has a question, so I was going to ask him to unmute. Let me see if I can ask him. Martin, do you have a question that you wanted one of us to?
Yeah, hello. Yeah, I just wrote the question into the chat. So I was talking to Daniel Müller, and we had the question, can different NSRs respond different regarding to the reasons why PRRT might not work?
I'm not sure if I understand your question yet. Different NSRs respond different regarding. Well, the first part, you mean different NSRs in the body, different locations?
Yeah,
Could they respond differently?
I mean, it's about you find those NSRs. You have the 1 minute exam, and when you start treating, you would try to use the reflexes to calm them down. So, is there something, maybe if you do something for the lower back, or for the yeah, let's talk about lower back. You will do something and the NSRs didn't respond well to this, but when I do something maybe in the cervical spine, this working very well, but I can't get the lower point away. So you know what I mean?
Yes, absolutely. That's kind of back to you haven't found the through line yet. So I run into this all the time where I'm like, this should work. In my head, I'm going, this should release. They should be let go, and it's not happening. And so in my mind, I'm going, what is this telling me? What is their body telling me? This is a clue. What is the clue telling me? What's next? Where should I look next? What am I missing?
Okay.
You know, what have I not figured out yet? And it's just, for me, it's just staying in that mindset that I don't have the answer. I'm going to find the answer. The nervous system, what it comes down to is, you know, the most current understanding of pain is that there's no such thing as like pain here.
Yeah.
I mean, we feel it, it's real, right? But pain is your brain interpreting all the feedback it's getting from the body, and then it makes pain here, so you feel it there, right? When you are with what you just described, every time you do a treatment, you're forcing the brain to change its interpretation, to reinterpret what all this, the balance of all this information means. And the reason that the low back hasn't let go yet is because for some reason the brain still thinks that there's something wrong at the low back and you need to pay attention to it, or you need to not have access to motion there, or both.
Okay.
Right. And so that's what's on my mind is what else could make the brain want to do that? So the obvious answer is always to look around that area. We look at the area, but then we look upstream, downstream, to the sides, you know, inside, outside. Look at the neighbors. But if that's not it, then I start thinking deeper, like, what else is wired to this area? What other areas share wiring or wiring interactions with this that aren't quite as obvious? And I start thinking there. And sometimes I often have to open a book and just remind myself, because I know a lot of stuff, but I can't recall it all. Like I don't have everything memorized. I don't bother memorizing things I can go look up in a book. I'm more in tune with how do I solve problems and keeping my mind open to the answer here may be something I've never seen before and no book has ever told me. And oftentimes that's the case.
And for this question, we have a second part. So there's a long list about why might PRRT fail. And we want to know if you have any experience about maybe something like osteoporosis or statins or something else. If you find that PRRT is not working about some NSRs, is there an all-in thing? So if there's osteoporosis, you shouldn't use it, or is there something partially maybe you can help, or do you have any experience about that?
Erick pulled up this long list of reasons it might not work, and I think the way to consider this is back to what I was saying about the answer is it depends on the patient.
Yeah. Okay.
So and it comes combined with the nervous system the brain is interpreting what all this input means.
Yeah.
My expertise isn't in, like, I know some things about nutrition, but I'm definitely not an expert in nutrition. you know, or, you know, hormones. Do I know, I have a pre-med degree. Do I know a lot about hormones? I know a lot about hormones. Do I think I know a lot? No, I don't know very much at all. Like, because I know people who really know. I ski every day, every week with an 80-year-old retired endocrinologist. Like, you know, he knows about hormones.
Okay.
You know, it's for me, what's made me successful is recognizing what I don't know and recognizing the signs of that and following that clue. Like, to ask about the things that were on the list that Erick brought up, or ask questions that lead to them acknowledging they have those things. And they say, well, could this cause it? And I go, well, it could. I'm not sure if it does. And sometimes it's stuff that is in my wheelhouse. And I go, I know enough to know that definitely is a likely cause. And I think it's worth going to your doctor. And I coach them on how to talk to their doctor. So that I'm like, I think if I were you, I would go to if I were in your shoes, I would go to the doctor and I would say, hey, I've got this problem. This is what it looks like. This is what I've done about it. It's just, I've been talking with my biomechanist or with my, whatever you are.
Yeah.
And we both think it's likely there may be this component that's in your wheelhouse that I need your help. Do you think we should look in this area? I think we should look in this area. What do you think? You know, so that you're going to your doctor collaboratively rather than I hurt, fix it.
Yeah.
Right?
Okay. Okay.
Because all of those systems can affect, the nervous system is tied to all of them, right? Remember, it's the motherboard. It's the central hub. So all of that is fair game.
Yeah, okay. I guess that's really a good answer for us. The next thing, do you have a good technique for the ligamentum nuchae release? Something for that?
Oh yeah, we did that in level 1, and was it 1 or 2?
Okay.
The basket weave.
Maybe we missed it.
The ligamentum nuchae basket one, I think, is in levels 3 or 4, actually.
Oh.
Okay. Okay.
That's in our next class in 2 weeks.
Okay.
But
then we will wait. Okay.
But you're on the call, Erick. We got to share.
Yeah, give everybody the bonus here.
So
since they're joining us live, Jeremiah, maybe you can demonstrate.
Oh, and we use this all the time. This is among one of those moves that you use constantly.
Yeah.
So the trapezius attaches into the ligamentum nuchae as well as other things, right?
Yeah.
So what you do is you interlock your fingers like this, and you've got the ligamentum nuchae right in between, right?
Yeah.
Ligamentum nuchae is the pen. My fingers are in between, right?
Yeah.
So I've got their head like that. And what I do is I kind of palpate and kind of rub and get them loose. And then I very quickly pull my fingers apart. And I'm just sort of flicking the ligamentum nuchae. I'm not trying to rip it. I'm just trying to flick it in both directions with my fingers like that.
Okay, nice.
And it most time instantly has a powerful release on the ligament and the trapezius that attaches into it. The ligamentum nuchae has direct attachment to the dura between C1 and C2. And so it's going to have a downregulating effect on the dura matter. So it's a really, really powerful technique. So try that this week.
Yeah, sure.
Hopefully we'll see you level 3 in 2 weeks.
I'm very sure of that.
They're going to be on.
Fantastic. Yeah, well, you got the head start. Maybe we'll have you practice it and then you can teach it in the course. I see people when I teach, for those of you who haven't experienced me teaching, anytime I see someone do a technique, I'm like, that's how to do that. That's better than I do it. You know, well, they got some insight. I'm like, Erick, can you put the camera on them? Like, everybody watch that person, right? Like back what I was saying about ego, like, the more you can have a healthy ego and know you're okay. I'm competent at teaching, competent at treating. I have the skills I have, and I don't have the knowledge I don't have, and that's okay. The more successful you're going to be with your patients and also professionally among other professionals, and the more you're going to be able to actually integrate in the world to operate, and it'll give you the power you make the choices you want. Like I run my business I don't have to deal with insurance. Like, people are willing to pay me and my employee to work on them. They give me the time I ask. It's once they realize that I'm not going to try to have them in here every week forever, that I'm here to solve their problem. And then the only people I work with ongoing forever are the ones who want me to keep coaching them. And I'm willing to do it because we're making progress towards goals, not because they just need an appointment.
Yeah.
Like the more you can, the more it all comes down to this ego issue. So, and it's not to say that like all of us, I don't know you personally, but I just know that it's common that I'm not saying that all of us have an ego, like we're like, oh, look at me, but as practitioners, we have a certain level of pride in what we've put into the work and wanting to get results. And sometimes we feel obligated to have the answer. And it's okay that we don't have the answer, but we need to be contributing responsibly to it, right? To the answer and actively engaged in it. And that's always okay, right? We only really do real damage when we're like, no, it's my answer, or it's not, that kind of. None of us need the God complex. I had a patient recently say something. He said, "Oh, you mean you're not an M deity?" I'm like, I've never heard that before. I'm going to steal that. Yeah, like we just need to all avoid that, right? Most of the docs I know that are younger and coming through school, that's not being taught. That kind of mindset is not as actively taught as it used to be. In the medical profession, like the culture is changing slowly, but it is changing. And it's true in kind of the chiropractic field. They have their own version of it historically, and we just all need to move away from that. like we're all going to work. We all work a lot better when we work together. And everybody I've ever met that has that kind of mindset does really, really well. So it's okay. That starts with, it's okay not to have the answer, right?
Can I ask one last question from our list?
Sure.
Or?
Yeah, go ahead.
So how often does the work usually needed to replicate it, solidify it with homework or session repetitions? So we want to know if you have any experience. When you have a client, you will use some reflex stuff and they're feeling fine, going home, coming back again, have the same stuff again. Is there any experience about maybe there's a second session and then it should be done, or is there something else overlying or something like this? Or should I give some homework to stabilize the joints around it? Or
that's what I do. So back to what I was saying, I have a model. And I'm modifying how I deliver that model for the person, like where I pick from and what I'm doing. I do it based on the person, but there is a human model or design, right? So there's a global question. How do I get the nervous system into a state where homeostasis, if you will, is everything's homeostasis, but like even when they're all worked up, they're in homeostasis, right? That's the body's answer to dealing with whatever stress it's dealing with. But how do I get it into a state that's more balanced, that is sustainable, that's a healthy way of being? And what do they need to keep them there? Sometimes the answer is they need to know how to use, now that you got them balanced, they could get access to a posture that they couldn't get access to before, that's healthy and stabilizing, and that's what they need. Because when they don't stabilize their lumbopelvic joints appropriately, that's what triggers them back into this compensated, neurologically upregulated state that causes all these pain issues and NSRs. Another person, it could be their mental state. And that may or may not be in your wheelhouse, right? I've had those. I don't advertise this, but they run into me. They find me. And I've done borderline therapy work, not because I'm trying to do therapy, just because I'm listening to them. They start telling me things and I listen. And sometimes I just, I'm not trying to do therapy, and I really don't try to engage it, but Sometimes I just know what they're listening to them, and then reflecting on what I'm hearing helps them work through it. And they start solving their own problem just because I'm able to go, it sounds like that really bothers you like this. And you've told it to me 5 times the same. You've said it 5 different ways, but every time you respond like this. Do you think you could do that differently? And they say, well, no, because it always, I'm like, but do you think there'd be possible if next time you feel, well, how would I know? Because every time you told me it got triggered, you felt like this. Does it always feel that way? Right. Like ask them, does it always feel like that when you get triggered emotionally like this? Yeah, no matter how it happens, it always feels that way. Okay, next time you feel that way, do you think you could recognize it and stop? Do you recognize it when it happens? Actually, yeah, I do. Could you choose this week to stop yourself and do one thing different? Just choose the way you're going to respond. I had someone I specifically did that with. It took less than a week before it happened. She had done everything mechanically and neurologically right to get, she had this, forward neck and, thoracic kyphosis, and she had been making progress, but months, and she had gotten from here to like here. And I'm like, how do I solve this? And what I'm describing to you happened.
Yeah.
And she was talking about the kind of stuff that you don't just interrupt somebody and say, we don't talk about that. Because I had the time. And we talked for like 2.5 hours because I just had a light day. And 2 weeks later, she was back in my office and she was like this. And I went, duh. I was a little embarrassed. I was excited and I was embarrassed at the same time, but I learned what drove this wasn't mechanical at all.
Yeah.
It was the conflict in her life that she needed help with. And so, and I helped her. I didn't solve it for her, but I helped her deal with it in a way that was productive. And I encouraged her to seek like professional therapy help, because I'm like, we need to find somebody you can work with to continue this work, because I don't have that skill and I'm not that person, but you would really benefit from this, right?
Yeah.
So I hope that illustrates the point.
Yeah, sure. That helped. So thank you for answering our questions.
You're welcome. Glad to do it. I look forward to seeing you in class in 2 weeks.
I'm not sure I can join live, but it will be a pleasure.
Well, we'll keep you in mind. If I know you're going to be listening.
Well, that pretty much brings us to, I know Martin's joining us, but I wanted to be sure that everybody else knew about the upcoming level 3 course. I'm going to share the screen real quick. Let me. We have it's scheduled for 2 weeks from Friday, so I know that it's pretty last minute for those that are on the call to be joining us for the live course. But just to go through quickly what's going to be covered, we have over 40 new techniques, a new half-minute exam. We already touched on the grade 5 fascial releases, and there's just a ton more, plus close to $500 in bonuses. This is all listed on our calendar page. So I just wanted you to see the pricing now for our Zoom attendees. If you register using the early bird and use the code Zoom, you can get $100 off your registration. But what I really wanted to talk about is the virtual option that we have available, that Martin is joining and a few others I think that are on the call are going to be part of. You can join us as a virtual student, and you can see that rather than paying, $1,800, you have the option of attending as a virtual student as just, the live stream for as low as $795. So you're saving a bunch right up front just by joining, and you can do it from your own home, so you're saving on travel costs and all that as well. And since we are throwing out bonuses, we recorded the last combined course with Jeremiah. And if you sign up for our virtual seminar and you aren't a former virtual student, you will get access to the recordings from the last combined program. So I will drop the link here so that you can check it out if you're interested. And I think there was one more. Let's see, what are the lab practice and recordings? The lab practice and recordings, it just says Samsung, so I don't know who's asking the question, but in the chat, somebody asked, what are lab practice and exam recordings? So the exam is the 30-second half-minute exam that we go through during level 3, and you'll get the recorded version of Jeremiah demonstrating that. The lab practice sessions are when the students are performing the exam and the techniques on each other. But that's what those are. If you just sign up for the standard, the $7.95 option, that gives you access to the Zoom, so you get live stream video. The other options are for the recordings. So let's see. Jeremiah, Dad, did you have anything else to share?
I got nothing else. I gotta go and
You gotta run.
Soon.
Well, we did
I got
good.
a patient here.
Okay. Are you sure you don't want to, just live stream the treatment process for us?
Thanks, Jeremiah. Thank you.
You're welcome. Thank
Okay.
you, guys. Thanks for being here,
Yeah.
everybody.
Thank you all. We appreciate you joining us. We will be in touch soon. Jordan said thank you. And yeah, I will wrap up for today. Thank you so much, everyone.
Bye-bye.
Bye-bye.